Hi, I'm Dr. Peter Valenzuela. I'm a practicing family physician and also the chief medical officer of a multi-specialty medical group in California. We've been on value-based care models for years now, and approximately a third of our payers do pay us in a value-based care model. So I'm super excited to be talking to you about this topic, and I look forward to walking you through this process. So let's get started. And we have 5 key objectives for this video presentation. The first is to explain the drivers that are leading to value-based care. The second objective is to provide a high-level overview of value-based care, including core components and terminology. And now the third objective is to describe the benefits of value-based care for family physicians. The fourth objective is to list potential challenges and keys to success in developing value-based models. And the fifth and final objective will be to provide resources to help you get enrolled in programs and learn more about them. I know this is a lot to unpack, but I'm confident you'll be able to follow along and walk away with some excellent insights. Let's begin with understanding the drivers leading to value-based care. Now, in the United States, we currently spend $4 trillion on healthcare. As you can see from the bar graphs, this amounts to a little over 18% of our gross domestic product. What's even more alarming is that according to the Centers for Medicare and Medicaid Services, our spending is predicted to increase to $5.4 trillion by 2024 and climb to as high as $6 trillion by 2027. That's about 20% of our gross domestic product here in the United States. So where are we spending this money? As you can see on the pie chart, we spent $4.1 trillion on healthcare in 2020. Of that, about a third of costs were hospital care and hospital related. Now, this includes hospitalizations as well as anything that's billed via hospital-based entities like surgery centers and infusion centers and hospital-based labs. The next service you can see is physician services. And this isn't directly necessarily all physician charges. These are services provided by physicians on the ambulatory setting. It includes outpatient care centers, it includes lab services and others that are not hospital related. And finally, as you can see there in the green, we have prescription drugs that make up about 10% of our costs as well. Actually 8.4, but some high utilizers of expenses. Now, based on this pie chart, you can see how much we're spending. So why are we spending so much? What are the main drivers of rising costs? Well, the first is that people are sicker. 1/2 of Americans have at least one chronic condition, and 1/3 have multiple chronic conditions. Second driver is that the US population has continued to grow. Despite being sicker, life expectancy is actually higher than it was 40 years ago. It's averaging about 76 at this point. Now, in the last few years, I will give a caveat, we did see a drop in life expectancy, but that was mostly due to the pandemic. And for the past 100 years, it's really been continuing to rise. The third driver is how often we utilize medical services in the United States. Given the older population and disease prevalence, and a model right now that we've seen that rewards utilization, it's no surprise that we see high utilization and volumes now. Another major contributor for this utilization is duplicate services due to poor coordination. Most often, this is lack of interoperability between electronic medical records that forces providers to repeat labs or tests because they're not able to talk to EMRs that provide the results to these services that have been done already in the past. And the fourth driver of rising costs is service price and intensity. Most patients aren't aware of the cost of care at different facilities, especially if they have insurance. For example, approximately 2/3 of hospital emergency room visits annually by privately insured individuals in the United States are avoidable. And to understand that, you have to realize that ER visit costs are 12 times higher than being treated at a physician's office and 10 times higher than a visit to urgent care. Now, are we getting our money's worth? As you can see from these bulleted points, when you compare the United States to other members of the Organization for Economic and Cooperation, you can see that the US spends more on healthcare as a share of the economy, nearly twice as much as the average OECD country. Yet we have the lowest life expectancy and the highest suicide rates among these nations. We also have the highest chronic disease burden and obesity rate that's twice as high as the other people. And compared to our peer nations, we have the highest number of hospitalizations from preventable causes and the highest rate of avoidable deaths. When I talk about the OECD, just to let you know for your information, there are 11 nations included, and that is the United States, Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, and the UK. Now, I will say that they all have universal health care, but that's probably more information for another conversation. So let's begin with an understanding of the drivers leading to value-based care. This is the definition of high-value care. Now, depending on who is just defining it, you can see different points that each tries to make. The National Academy of Medicine says that high-value care is safe, timely, effective, efficient, equitable, and patient-centered. Whereas when you look at the Institute for Healthcare Improvement, they really are looking at the improvement of the population. And they want high patient experience and ultimately reduce per capita costs. When you look at the value equation, it's really that kind of quality is equal to the service over cost. And that's really what we're looking at when we define high value care. Let's look at what that means from a payer perspective. Payers use alternative payment models, which they call value-based, as a payment approach that gives added incentive payments to provide high value and cost-efficient care. Now, right now, 40% of payments are tied to alternative payment models based on an LAN survey in 2020. And as we move forward, we're going to be seeing more of that. When you look at alternative payment models, they can really apply to different things like health conditions, kidney disease, care episode like being hospitalized for a joint replacement, provider type like payment for primary care, communities like payment models for community health in rural areas, and innovation within Medicare Advantage or Medicare Part D. There are different programs related to that. There's four main types of value-based payment models. At this point, most of what we see is still traditional fee-for-service, but they are for fee-for-service models that are tied to performance-based payment, right? So you do get fee-for-service, but you actually get additional payment based on achievement of certain metrics or completion of certain activities, right? And P4P models, you actually give bonuses for quality metrics related to patient safety and patient experience and making sure that you're hitting your diabetic marks and things like that. When you look at the bundle payments, right, what happens is instead of paying separately for the hospital bill and the physician bill, you actually bundle all of the payments together. And it's usually linked to a particular condition like a procedure. We're seeing this a lot with orthopedic procedures now, where there's one big payment for 30-day span from surgery, and you get the same dollar amount no matter how often that patient is seen, whether they're admitted or readmitted, it's the same bundled payment amount. So it does incentivize making sure there's coordination and good quality care being done. When you look at shared savings and risk, that's really being paid using a traditional fee-for-service model, but at the end of the year, the total spending is compared with the target. So if the provider organization is spending below the target, it gets to share some of the differences of a bonus. But if you spend more taking care of this population, you end up repaying some of the differences as a penalty. So there's upside and downside risks a lot of times. And we have been seeing shared savings models recently with Medicare shared savings programs. So there are some people already involved in this related to hospitals. And then capitation is something that's been around for decades. It was very popular in the 80s and 90s, and it kind of went away, and now it's coming back. And when you look at global capitation, that's when a provider gets a fixed payment per person per month that's intended to pay for all of the individual's care, regardless of whether they use the services or not. And there's also primary care capitation, which pays the provider for a fixed amount for primary care services only for select individuals. Now, this tends to be the most advanced alternative payment model because it's higher risk for people that are caring for patients. So let's talk. We talked briefly about payment models and what they mean and risk and how much integration is needed. As you can see in this graph here, there is a roadmap that shows you from the least amount of risk and least integrated to the highest financial risk and also the highest integrated. Now you stand to gain a lot more money the more integrated you are and the more risk you take on. So looking from left to right, you can go from fee for service to performance-based contracting to shared savings plans to shared risks, all the way to capitation, and then capitation with performance-based contracting. Now let's talk about it from the provider side. Value-based healthcare is a healthcare delivery model where providers, including hospitals and physicians, are paid based on patient health outcomes. In other words, we're rewarded for helping patients improve their health. When you look at value-based care delivery models, these tend to be the most common that you see. There's the ACO, or Accountable Care Organization. There's the CIN, or Clinically Integrated Network. There's a PCMH, or Patient-Centered Medical Home. And then there's this population health service organizations. Now let's kind of break through each of them individually. An ACO is a group of clinicians and hospitals and other healthcare providers who come together voluntarily to give coordinated, high-quality care for a designated group of patients. It's usually different types of conditions that I've alluded to in the past: cardiovascular disease, endocrine diseases like diabetes and other conditions, surgical cases. And really the goal is to work together to have better outcomes for that population and lower costs. When you look at a clinically integrated network, it's usually a selective partnership of physicians who are collaborating with hospitals to deliver evidence-based care. They also want to improve quality and efficiency and better coordinate the care so they can demonstrate value to the market. Basically, a CIN is any group of providers that has effectively coordinated the clinical services provided to patients across the care continuum. Now, PCMH, a lot of primary care physicians know much about. It's been around for a while, and that is the patient-centered medical home. And it's really an approach for delivering high-quality, cost-effective primary care. You try to use a patient-centered, culturally appropriate, and team-based approach to coordinate patient care across the healthcare system. Now, again, PCMH is a model that emphasizes the role of a single patient-selected physician who ends up being the quarterback or the gatekeeper to ultimately be responsible for planning, delivering, and coordinating patient care, both within the care center in the ambulatory side, but also trying to keep them out of the hospital side. Now, Population Health Services Organization provides the resources and programs to deliver kind of this rule-based care to effectively and efficiently manage the health of the population. Now, the way the name implies, the model is really there to focus on provision of population health services. So they do things like engagement and patient outreach and care coordination, chronic disease management, complex care management. A lot of smaller organizations who don't have the infrastructure will partner or contract with these population health services organizations to provide that infrastructure so they can achieve the metrics that we're talking about. So as you can see here on the graph, you have these similar attributes as well as how they differ. And I'm not going to walk through each of them, but I think the information here is self-explanatory. So having talked about value-based care, having talked about our healthcare spending now and where we are, what it is payers want to see, and how providers are delivering care, let's talk about the role of family physicians in value-based care. So our national shift from fee-for-service to value-based care will rely heavily on a strong primary care backbone. Primary care has traditionally been underfunded and overworked. Now, what we found is that even a small change in that calculation could dramatically improve our healthcare system. For every $100 we spend on healthcare in the United States, right now, only about $5 is spent on primary care. What we have found is that for every $1 invested in primary care, we actually save the healthcare systems up to about $13 for every dollar. So if we invest in primary care moving forward, we will dramatically drive value and decrease healthcare costs. So how do we do this? When you look at the role of primary care in this new model, there are different categories that you can look at to help defray costs or decrease costs. First, of course, is utilization. It's trying to prevent unnecessary inpatient admissions. Sometimes patients will be unable to get into the office or get through to the office, and they end up going to the ER for something that you probably could have cared for within your office, things like urinary tract infections or acute illnesses. You also want to minimize inappropriate or duplicative care. And what that is when you have patients within your care center who have seen other physicians or specialists and had tests done, but you don't have access to them or you're not able to find them, and you end up reordering those tests. Those are things that can be avoidable. And then it's also, referring patients to the most appropriate and efficient specialists. Sometimes you refer a patient for something that you could actually do yourself. Maybe for primary care, this could be a dermatologic procedure, cryotherapy. They could be a joint injection. And sometimes we refer to specialists who are higher utilizers of services, scans, and others, which can cost more dollars. You also want to look at clinical outcomes. As a primary care physician, the goal is to really proactively manage chronic illnesses. So making sure that you're getting those hemoglobin A1Cs on your diabetics and checking your cholesterol levels on your cardiovascular patients and monitoring those blood pressures. And finally, it's the expense management part, right? It's following evidence-based care pathways so that you are doing the right thing for the patient and saving dollars along the way. Examples of this could be not prescribing antibiotics for infections that are very highly likely viral, like pharyngitis, for example, bronchitis. Also, making sure that you are streamlining your cost by following your own family physician standards and evidence-based guidelines. This is the key for a lot of what we can do in a value-based model. So how are we going to be measured? This graph here shows some examples of common value-based metrics, okay? I've kind of alluded to some of them, but you can see they have ambulatory aspects like statins, cancer screening, A1Cs, but also emergency room and hospital metrics like ER visits, right? Hospital admissions, readmission rates. These are things that on the family care side, we can actually help guide, navigate, and even control. So what are the keys to success and challenges for value-based care? Let's begin with understanding these drivers now. Now, the Center for Healthcare Quality and Payment Reform really talks about these 4 key steps. And these 4 steps include identifying potentially avoidable spending. Okay, specific types of healthcare spending are both planned spending and unplanned spending. And again, both avoidable. When you look at planned care, these are categories that include ordering or delivering unnecessary tests or medications or procedures, or using expensive tests or treatments when a less expensive one could be equally effective. When I say that, it's like ordering an MRI when an ultrasound actually would probably give you the same level of information and cost less. Now, when we look about other avoidable spending, it's the unplanned care. This includes emergency department visits and hospitalizations for preventable exacerbations like COPD exacerbation, right? Or asthma exacerbation. These are things that can be controlled within the ambulatory side. Now, the second step, of course, is design an approach to delivering services that are expected to reduce avoidable spending. Every medical specialty has evidence-based clinical practice guidelines that indicates what types of tests, medications, and procedures are appropriate for specific types of patients, and what types of services are likely to reduce avoidable complications and prevent health problems. And what's going on right now is many patients aren't receiving these services consistent with evidence-based guidelines. And that is another avenue. Now, the third thing is really creating payments that give providers the ability to implement and sustain new approaches to service delivery. This is going to be really vital for us. You can't just give bonuses and penalties for providers. That really will not drive a lot of the change. We have to really implement programs that will pay for services ahead of time. so that you can actually manage the patient early, right? And then finally, we really need to hold ourselves accountable for delivering appropriate care that's evidence-based and really try to follow the guidelines that we talked about. These are the 4 vital steps to success that will get us to the future. Now, what are some of the challenges to implementation? First of all, it's probably the payments. Currently, a lot of value-based payments are a very small percentage of total dollars for physicians, and that is why many aren't participating. And really, to commit to value-based payments, you have to increase that percentages, right? Some payers right now only offering small payments for care coordination or savings, right? And for physicians, that means that when they see this patient who may be in one of these models, if it's a very small percentage of their total care, they end up treating them the same way and ordering or doing procedures that may not be needed, right? And so the other part, of course, is data reporting. It can be very clunky, right? Some physicians may be tracking conditions that are done elsewhere. Say a diabetic has an eye exam that's done at an ophthalmologist office. The primary care doctor might get that report and scan it into the records and put it into a table that's really hard to find later on. And so when you're measuring the quality metrics, you end up not getting credit for that report because it's not something that can be that's trackable. The other component that we think about is change management. Not having a change management plan can be a barrier to achieving better outcomes. Otherwise, what happens is a lot of physicians stick to what's called the old ways of their current practice patterns and caring for patients the way they know how, which may not be the most effective way. Not to say that the care is lesser than, but it can be more expensive. Lack of incentives, right? Incentives under the fee-for-service model is really productivity, right? The more bill charges, the greater the potential for financial services. And in value-based care, this is where clinical outcomes and patient utilization and patient experience are more important. And organizations have to institute appropriate incentives for clients and staff to reward performance in this area. A lot of that will also be transparent reporting that we talk about. And most finally, when you look at a challenge, it's going to be coding challenges, right? Inaccurate or imprecise diagnosis codings will hinder long-term success for value-based payment models because the higher the risk score for the patients that you're caring for, the higher your value-based incentives. So you have to correctly code a patient with diabetes complications like diabetic neuropathy or other conditions to make sure that it supports that performance pay that you receive, right? It also kind of gives you a better clinical understanding of your patient panel, right? So these are some of the challenges that we're facing now that we'll have to overcome to help drive us to these value-based payment models. For those of you who are wondering how to get started in this type of a model, so the Texas Medical Association is working on developing a site for services, whether you're a small solo practice physician or a large politically integrated network. There's going to be resources to help guide you and help you understand better what you can do to dip your toe in the water on value-based care models and how you can better care for patients in a cost-effective way. So in summary, we know that our current payment system is not sustainable. We're spending over $4 trillion a year on healthcare, and it's on pathways to be about $6 trillion by 2027. We need to focus on models that care for patients on value and outcomes. We already know that CMS has said that by 2025, 100% of their payment will be on some type of alternative payment model. And insurers also are moving to at least 50% in value-based model moving forward. And in order to be successful under these new payment models, we have to understand and embrace them to thrive in the new healthcare environment. Thank you very much, Dr. Peter Valenzuela. I appreciate your time through this video.